be here. I was asked to address those 3 points that Mark just went over, and to do it in about 8 minutes. So I have very few slides, but I want to talk a little bit about perspective on current state, what are the priority outcomes we want to get done in a few years, and how do we get there. Just as a disclaimer, I have been a consultant or am a consultant on distance support to a number of groups. And I'll talk about something called OpenCDS, but I have no competing interest there. So I think our perspectives are based on our background. So just want to briefly give a sense of where my thoughts of where we are and where we need to go come from. So right now I'm pretty heavily involved in operational IT and informatics. I'm about 60% allocated there, and also get to almost be a fly on the wall for a lot of the executive level decisions that get made in our healthcare system. I'm our informatics liaison, for example, for governance board, for how we react to healthcare reform, for example. So I'm all in these meetings with everyone else being C-level executives. I also co-chair the HL7 Clinical Distance Support Work Group, so have been in the standard space for a while. I founded this initiative called OpenCDS, which is an open source standards-based way to do clinical distance support, and include support for personalized medicine. I'm also the initiative coordinator for the Office of the National Coordinator's Health E-Decisions Initiative. So this is the government's initiative right now to develop and validate standards for consideration for being potentially included to meaningful use stage 3. So I'll just get right into my sense of where we are. So when I look at the current landscape, Mark mentioned this, there is some emerging support for structured family history data. And if you look at meaningful use stage 2, there's an optional measure that says one of the measures you can meet is 20% or more of your patients must have at least one first-degree relative family history in the record. And my sense is, well, if you support first-degree relatives, you probably support second-degree relatives, et cetera. So I think that's a great thing. I mean, it may not be perfect, but I think that's a great start. My next two sort of assessments are a little bit less optimistic. So my sense is distance support for personalized medicine is generally not aligned with what primarily drives health systems, IT departments, EHR vendors, the key players really in the space for whether things are going to move forward. So I would characterize this as low demand for what we're talking about. There isn't key stakeholders saying this is what we must do and this is our priority. So some specific things I think are meaningful use. Meaningful use is a driver for a lot of these groups, and it's there but in a weak form in terms of just capturing family history. And I think really important, probably more important, is the notion of a return on investment. We really haven't done a good job of showing this is something that's good for your bottom line, good for keeping your margins. So Mark mentioned most health systems run on a pretty thin margin, and it's projected that the margins are going to go negative very soon. So in that environment, you're really focused on keeping your business alive. You're not really focused on what can we do that's the next generation of how we can care for patients. I think, so as a result, it's an institutional priority for very few organizations. There's notable organizations where this is a priority, and they've invested, but I would say that's definitely the exception rather than the norm. And this is dependent on grant funding for the most part, which limits impact. So when you talk about millions of dollars being the grant funding model versus a lot of these institutions are spending hundreds of millions of dollars. Partners, I think, just spent $1 billion on their next EMR purchase. You know, you can see that the scale of spending is very different. And I think for bigger impact, you need to tap into what's the organizational priority for these health systems. And on the flip side of low demand, distance support for personalized medicine is generally expensive and difficult. So not many people are asking for it, and when you try to do it, it's very expensive. So part of this is strategies to enable this approach oftentimes require infrastructure that's not widely available, like full pedigrees being available for all your patients in a structured way or structured genetic data. So oftentimes just to do what we want to do, we have to change things. We have to implement something new. We have to ask IT to do something. And that is expensive. And a lot of the folks who are needed are people that are like in this room who are typically busy people, fairly expensive people. And it's a challenge. And I wouldn't say this is always the case, but a lot of existing approaches are not easily scalable to other institutions. So I think it's the kind of thing where you ask someone, hey, that's great. How do I get it done at my institution? And usually the answer is, oh, just download this, tell your IT person to press this button, and you'll be done. That's typically not the way it's done. And that is high cost. It requires effort. So to get to where we want to get, we are taking care of patients the best way possible with personalized medicine. Here's my thoughts on some priority outcomes. What do we want things to look like in a few years? So I think it's important that what we're talking about here is aligned with meaningful use. I mean, the bottom line is it is a big driver for what goes on, and that's an important consideration. I do think we have to really make a clear case for what's the return on investment. In the bottom line case, I mean, you have to be able to say, if you want access to operational dollars to do things, why should our institution invest in this? And I think that's a case we really have to work hard to try to make. And we need to make, I think ideally in a few years, the cost or difficulty of enabling this type of distance support should be dramatically reduced. So you want to make it so it's easy. You want to make it so that when you hear that somebody else has been able to do this, it's literally, oh yeah, my IT guy will get in touch with your IT guy and they can get this done within a day. That's where we need to get if we really want this to scale. So some recommendations. So along these lines, the first recommendation I'd have is to align with the Office of the National Coordinator for Health IT's Health E-Decisions initiative. And as I mentioned, I'm the initiative coordinator for this, so I'm a little bit biased on it, but I do think it's relevant for meaningful use. So we're developing two complementary approaches to interoperability. So one is the notion of a universal import format for order sets, documentation templates, and rules. So things like alerts, reminders, and order checks. So the notion here is, for example, that a user of any electronic health record system can import a standard clinical reminder that says, okay, here's the U.S. Preventive Services Task Force guideline for breast cancer genetic screening based on family history. So you say, oh, that looks good. I'll import it into my system. I can just hit a button and it gets sucked into my system, maybe a little bit of configuration. So we do have a draft standard for that was approved earlier this year. The one we're currently working on is a universal interface for electronic health record systems to obtain patient-specific care guidance from what we call clinical distance support web services. So in this example, say you're a user of any electronic health record system and you can just ask your IT guy, hey, can you just configure us to hit this service so that I can get family history data sent, relevant clinical data sent, and get guidance on what should be done for this patient, for example, according to this U.S. Preventive Services Task Force guideline. So this is in contrast to the present day where you have to ask your IT person, can you implement this thing where it says first degree relative is this, at this many second degree relatives, oh, and they can't be an Ashkenazi Jew. If that's the case, then you can imagine the difference where you can say, oh, just import this thing that's available here, or just point to this service and we're done. So this has a lot of active work, a lot of vendors participating for demonstration projects. And right now, the next 5 to 8 weeks, we're defining exactly what we're talking about. Things like, what data are we going to support for this distance support service? And we have active work going on. If anybody's interested, that's the space to get into. And please get in touch with me and I can get you hooked up. So the next recommendation is around this notion of return on investment. So I think common thing to think about is, in a lot of healthcare we talk about, is it greater than less than $50,000 per quality adjusted life year saved for drugs things. The big difference is drugs, devices, they're reimbursed in healthcare. Health IT is not. So health IT investment isn't subject to reimbursement or payment outside of meaningful use. So contrast that to things like an OR expansion or MRI scanner acquisition, where you can make a very clear, easy case. This is the return we're going to get. We need to be able to make a similar kind of argument, or it's not going to be there. So we need this case to prioritize within a health system this kind of approach over other competing demands on IT, like meaningful use, regulatory compliance, clinical documentation improvement. That's basically documenting better so you get paid better, those kind of things. And at the same time, there's really limited evidence on return on investment for distance support with or without personalized medicine. So we just completed a systematic review for distance support in the inpatient setting, variety of study types, pretty loose criteria to try to figure out, what evidence is there for that distance support is good for you financially in the inpatient setting. And we just found one true return on investment study that looked at both benefits and costs. So if you just sort of think about that, and that's for any clinical distance support, you can clearly get a sense that we're missing some things here. Others mentioned this, but there's new opportunities with the changing healthcare payment models, where there's dramatic changes going on in how we get paid. And there's a lot of, I think, new opportunities for identifying how this kind of a more preventive approach is actually in the financial interest of relevant clinical stakeholders and healthcare stakeholders. So this is just my final slide. The final recommendation is to reduce costs of doing this. Make it easier. Make it so you don't have to get a bunch of people with PhDs and MDs and HL7 long timers to get together to figure this out. So one recommendation here is to focus on approaches that can leverage existing infrastructure. This is not to say we shouldn't build a better infrastructure. I'm just saying let's not wait until we have nirvana with structured data flowing everywhere in exactly the way we want it. So let's look at using existing family history documentation and genetic test result reporting and figure out how can we scale that better. What are ways we can do this without having to change some things that we found are very difficult to change. We can also use things like these distance support web services, which Healthy Decisions is working on. And I'll just note that this is supported in the next release of one of the EMR systems, Epic. We can also look outside of personalized medicine. I think genetic exceptionalism tends to take hold outside of just genetics, but also people who work on genetics and sort of their thinking around it. And I think we really need to think of personalized medicine as not special, but leveraging specific, different aspects of a general purpose way of looking at healthcare. So there's a lot of initiatives that are general purpose that are designed to achieve universal low-cost distance support. Healthy Decisions is one of them. I'll just mention OpenCDS, which is something we initiated through some NHGRI funding. It's open source. It's a freely available implementation of this, we'll see may become meaningful use stage 3 approach to doing distance support. And just as an example, we have collaborators who've used this and made an open source, freely available immunization distance support system. They have public health experts, physicians. They've all vetted all the ACIP CDC guidelines for immunizations. And it's being used by New York City, Alabama State, and a EMR vendor called eClinicalWorks. So an example, this can be done where people who don't have any grant funding at stake say this is the easiest way to get things done. And I think in terms of grant funding, I think it's important to target it to approaches that have low implementation costs and can be easily scaled. It oftentimes won't be the most exciting, application that looks the most innovative. This is what the future should look like in terms of, the ideal case. But I think we really need to shift in mindset to say, what is likely to be adopted by a community hospital where, there is nobody who's done a biomedical informatics training program on staff, that kind of thing. So with that, I'd like to thank you and move to the next presentation.